rise in the burden of chronic kidney diseases will be exceeded even by a greater proportion. We have some early data which is currently in review to show that almost a third of all the deaths in some parts of India are due to kidney disease in adult population. This is really frightening, and this hasn't received the kind of attention it deserves. There was a report that was published a couple of years ago which compared the various causes of death around the world, not around the world, but in US and UK initially, and looked at how much attention it receives in popular media. And they looked at mentions in New York Times, The Guardian, and a couple of other prominent newspapers. And kidney disease actually appeared as the most lopsided of all the causes of death in terms of its importance as the actual cause of death and the attention it got in the media. So we need to do more as a community to increase awareness, but we also need to come with sustainable solutions. It's really important that we don't just lament the absence of this and develop sustainable solutions and present that to policymakers. We do good communication. I think there are sustainable solutions which are available, and perhaps they will be discussed later on. And a number of groups are working on finding those sustainable solutions in various parts of the world also, using point-of-care devices, identifying the real high-risk populations. The reason this is more important now than anywhere else is also that we have tools to arrest the progression of these kidney diseases. And these tools were not available until even a couple of years ago. Until 2 years ago, the only drug which works to some extent in reducing the progression of kidney disease was ACE inhibitors and angiotensin receptor blockers. But in the last couple of years, we have seen a number of new drugs being tried, tested, and proven through clinical trials that they are effective. So it's important that we take this information and this evidence to the patients who are likely to benefit the most from these interventions, and also keep in mind the need of the vulnerable populations who don't have anyone to advocate for them, to make sure that these treatments reach these people and are not just skimmed off by the well-off, but really are delivered to everyone in an equitable manner. This is the message of the International Society of Nephrology and the World Kidney Day around the world, and the standard message of the World Kidney Day is kidney health for all, everywhere, in an equitable manner. Thank you.
Thank you very much, sir. Thank you very much, sir. Thank you very much, sir. Now coming to Smita Aron. She is the editor-chief of Hindustan Times. Ma'am, you have just listened to Dr. Vivekanand Jha, how serious is the problem across the world. And you have also heard the initial remarks, and you have heard this Mr. Sachdeva, Justice Sachdeva ji. So what do you think? What would be the role of the media in preventing the spread of this false, non-authenticated, non-scientifically studied, this kind of the therapy going on rampantly, I will say, at present? And we have seen the many of the young people with bodybuilders coming to us, well-built person who is doing gym every day, but he developed some proteinuria, some macroscopic hematuria. He comes to us, we do the biopsy, kidney is looking totally fibrosed. Probably because of some of the non-studied, non-authenticated medicine he was taking to build up his body. So what do you think, ma'am, how the media should come into the role to prevent such a... just unmute yourself, ma'am.
Okay, thank you so much, Dr. Prasad, for inviting me. And right now, people see me as Dr. Narayan Prasad only. I don't mind it because I have more knowledge than. Otherwise, it's an honor to be Dr. Prasad, at least for some time. But my job is different, and my job is to talk about media and other things. Now, you see, if you recall that in newspapers and other periodicals and magazines, health was not covered so much till few years back. And the reason being that the people were picking up newspapers primarily, or they were watching news primarily to know what's happening around the world. It did cover scientific research and everything, but not ailments, Then after that, last few years, when we became health conscious as a society, I think it has to do with we were not at all bothered about our health some time back. I remember our parents telling us health is very important, and we said, no, it's everything is fine. If all of us are, when I say all of us, I'm not referring to the doctors, I'm referring to people in general. Were not very health conscious, and we became health conscious, and then after that people started taking interest in health matters, and newspapers also started giving information. And today, in fact, every day you will find some news on health, and even channels are running programs which are only on health only. But somehow there is a perception that heart, diabetes, and cancer, these are the three major problems that if you have, you die. People don't understand how your kidney problems can also lead to mortality. Till your doctor tells you that you have to go for a transplant, initial stages, I think nobody even bothers about it. So I think when we talk about awareness, the awareness has to start with how to keep your kidney healthy, why you have to keep it healthy, because you can die also. Otherwise, generally it is cancer and heart and diabetes is something, I don't know. That seems to be the most scary disease. You read most about diabetes in media. Now, the problem with the mainline media is today everybody has become a journalist. We are not the only ones who are, who can be called journalists. Everybody has become an expert on every subject, including, I'll talk about, my health reporter thinks that he knows everything. He's guiding everybody. So these problems happen because he's interacting with doctors. So for small little problems, we also tell them. I think that social media, that is one aspect of it. But when I talk about mainline media, I think we have to be proactive. And when we say proactive, your department, your people, the experts of this, and you have to be very, very simple. Today, I was going through a report filed by my reporter. It reads like a scientific journal. Now, the people who are reading my newspaper do not understand those jargons. They don't understand a lot of, the scientific terminology that is used. It has to be written in a very, very layman's language. I agree with you that we have to focus on awareness to prevent the spread of the disease, because once somebody gets it, then it is the most difficult thing to do. You know how our infrastructure is in the country. Either good doctors are in institutes and there is a big queue, or you go to the hospitals where you pay fat amount. What about the poor person? He doesn't, neither he can approach the big institutes because the queue is so long, and nor he can go to the fat where he has to pay a fat amount. I'm talking about public in general. So I agree that we have a major responsibility. Newspapers have a major responsibility. The channels have a major responsibility, but it has to be something which we have to do together. There is no way, because there are so many times when we approach doctors, they're busy, they don't have time to explain the small things, the small questions that we may be asking, and you must be thinking, what is he asking here? Why doesn't he understand even this much? But when the reporter is asking, that means the public is asking you. So I agree with you. As for the social media, as our Justice said, there has to be some type of regulation. I believe in that even if we have freedom of expression, at the same time, either we should understand our responsibilities, that freedom comes with certain responsibilities. And if you can't be responsible enough, then there has to be some type of a regulation on the information that you share on social media. Now, we don't know who's the doctor, who's an expert. There are 10 degrees written, next to when you go through the credentials, you'll find a whole lot of degrees added to it. How many people understand those degrees? They look at it, and because they don't have access to health system, they don't have access to treatment. The government system is pathetic, so they find it very easy to Google. So the Google doctors are becoming most popular, unfortunately, and that's where the problem is. That's where the problem is, and there we need to, because yes, we have ways to find, we can go to press council, we can go to medical council, but that is after we have suffered. My idea is, why after we have died, the family should run around? Why not before that? Why not do something that can save lives and help improve the system? So I agree with you totally that it is, but at the same time, we have to be more responsible while writing about it. So that's how I look at it.
Thank you very much, ma'am, for this great message. And always, there is always a confusion that when as you have rightly pointed out, we read more scientific papers, and most of the doctors have a habit of writing the data in terms of not in the layman language. We are writing in scientific language. So that is the problem. Yes. But can you say whether this society or any doctors should go to the general public with only the positive impact, or we should try to oppose the things which is happening wrong, like water bath kind of the treatment for a patient who is requiring dialysis? So what do you think, ma'am?
I couldn't get your question. I think there was some, your voice was cracking. If you could repeat your question.
Yes, ma'am. Suppose we are going to the media, we are going with the only positive things about this treatment, or there is something which is happening wrong, like the patient is getting water bath dialysis.
Both.
Dialysis which is not authenticated, not studied. So we should go for both.
Look, Dr. Prasad, sometimes you need to give a shock treatment. People don't wake up. And I'm sorry to say that there have been times when people were dying of illicit liquor. I took a picture on page 1, and that picture showed a dead body lying and a person standing just next to it and laughing. My idea was not to show a dead body, but to show the insensitivity of the person who was standing and laughing there. I think both. We have to work on both. And sometimes even shock treatment is required. It should come that you die of kidney problems also. It has to come. Why people were scared of COVID? Because it made you untouchable, one. Second, because you fear death. I think one thing that you fear most is death. So everybody wanted to know the best about COVID. Similarly, why everybody with a little pain now today in a heart would rush. Diabetes is another thing. I think there is so much of awareness being generated, still people are very careless about it. Although it can be now, there are so much of information about how you can check it, you can reverse it. I don't know how much you can reverse it. There are books on even your heart ailments that you can reverse them. How much you can trust them, I don't know. You are the people who know. But when you are sitting in an institute like PGI, your word matters more than any other private institute. I'm sorry to say that. I don't know who's from where. But because medical is everything is becoming commercial. So even the medical system is getting commercial. So if somebody is sitting in PGI is saying something, his voice will carry more weight than somebody sitting in a private institute.
Thank you, ma'am. Thank you very much.
Thank you.
So coming to Professor S.K. Agrawal, who is the editor of the Indian Journal of Nephrology and head of the Department of All India Institute of Medical Science, New Delhi. Sir, you have studied CKD prevalence about 15 years before. Do you think it is increasing, decreasing, or static currently, or it was similar before also, and now because of the awareness we are detecting more cases? Unmute yourself, sir. Unmute yourself.
Thank you, Narayan. You see, the change in the any disease is possible to comment once the similar type of studies are done with a gap of some years. Somehow those type of studies are still not available in our country. But one information which is not independent study but extrapolated from various data is a study which is global burden of disease, which India started as part of the global burden of disease of the world since 2015. And the data from global burden of disease concluded recently, although still unpublished, that it has compared the crude prevalence of chronic kidney disease in 1990 and in 2019. So it's a gap of approximately 3 decades. And what it demonstrated that crude chronic kidney disease prevalence in 1990 was 5.3%, which increased to 8.3% in 2019. So that is a comparison. One thing more important which has come out of this analysis is that the prevalence across India is not the same. So there are states where prevalence is significantly high as compared to other states, and in this analysis, the states which shows maximum high prevalence of chronic kidney disease were 3 states: Tamil Nadu, Kerala, and Punjab. And the study has tried to correlate the development index of the states and crude prevalence of chronic kidney disease. And there is a correlation that higher developed states are having higher prevalence of chronic kidney disease. It may be related to higher incidence of diabetes and hypertension in these states, or maybe to some degree related to more awareness and more capturing of chronic kidney disease patients. So that is what information we have as far as India is concerned in terms of the increase in the chronic kidney disease prevalence. And as we know that the diabetes and hypertension, and Dr. Vivek mentioned on a group of diseases which are labeled as chronic kidney disease of unknown origin are increasing and more detected. So this crude prevalence of CKD with time is going to increase. That's what I will say in terms of a change in the prevalence over time.
Thank you, sir. Thank you very much for making us aware about the present Indian scenario of the chronic kidney disease. We'll come for the second question in next round. Coming to Dr. Vivek Pute. You understand, we all understand that renal transplantation is the treatment of choice for any patient of the end-stage renal disease. Ultimately, they go for. But failing renal transplant is coming back again to the pool of CKD and end-stage renal disease, and again burdens the already burning situation. And one of the problems which is seen here is the non-compliance with the drug. That is another important issue. And many of, approximately, it has been seen non-compliance even in Western world up to the 40%. We don't have exact data in India, but it is not uncommon. It might be more than that in India. So how can government and society will help patients in reducing such a burden?
Thank you, Dr. Narayan sir. Non-compliance to the drug is more common in children. To overcome this issue, in the state of Gujarat, we have school health program, where any child below the age of 18 years get free treatment. There is no upper limit for this free treatment. So specific to the children, the school health program is providing free treatment for transplant, drugs, dialysis, non-transplant treatment. Then non-compliance in population other than children. We have 400 beds for taking care of patients with kidney disease, and additional 600 beds are now started in the next month. So we have total 1,000 beds. And we have 80 satellite dialysis centers, which are distributed in cities, district, tribal, rural, and coastal area of the Gujarat. In these 1,000 beds of dialysis also, the entire dialysis is free with the help of single-use dialyzer, single-use consumable, free erythropoietin, free iron. Apart from free treatment, the government provide rupees 300 for travel, so that there should be no non-compliance to the dialysis therapy. And we also provide free renal diet as prescribed by dietitian during their dialysis session. Under the Gujarat dialysis program, over the last 1 decade, the Kidney Institute has completed more than 15 lakhs dialysis session. And as on today, every year we perform 2.5 to 3 lakh dialysis session, where everything is free, including dialysis, including iron, erythropoietin, travel, and renal diet. Coming to the cost of all drugs which are needed for taking care of kidney patients, with the help of generic immunosuppression and tender system by government of Gujarat, we are able to provide medicines at very subsidized rate. For example, the cost MRP of mycophenolate mofetil is 800 rupees for 10 tablets. But Kidney Institute purchased this at 80 rupees. So we purchase and provide to the patient at 10% cost of the MRP, even if patient pay from their pocket. For example, 10 to 20 patient, 20% population who are in our institute, they pay from their pocket, which are who are coming from other states. So even if they pay from their pocket, we are providing them drugs at very subsidized rate, and cost of each drug is less than 20% of the MRP. If patient develop non-compliance and develop end-stage renal disease or end-stage organ failure, we have various government schemes like PMJY, Chief Minister Fund, Prime Minister Fund, then other state-sponsored schemes like Ma Yojana, where patients get free treatment. Almost 90% of the patients who are attending the Kidney Institute, which is largest public sector transplant hospital in India and largest dialysis network supported by state of Gujarat, we are providing them free treatment. So I think we have
it is possible that your institute is doing great for providing this free, but the scenario is different across India. So that is the problem. And even after giving the free treatment, there was a study from some of the states. I don't want to name the states. The pupils were not complying the advice of the doctors, coming twice or thrice weekly for the dialysis, despite being the free dialysis. So situation is a little different. It is possible that your institute is doing great and Gujarat per se is doing great. That is fine. But across India, the situation is not similar. So from on that point of view, I would like to have the opinion of Dr. Sanjay Agrawal. You are here, sir?
Yes, I am there.
Yeah. Sir, do you think Prime Minister of India has made every effort to provide free dialysis at the district level across India? and the efforts are recommendable and appreciated all across. Do you think this is sustainable cost-wise? How you think this will sustain such a heavy cost for the lifelong treatment on maintenance dialysis free for all?
See, there are many catch in this program. Number one is that this dialysis program is applicable to the persons who are below poverty line. And it is not applicable to a large group which is above poverty line but still cannot afford. Number two, that since the PM dialysis program has been established, if you see the number of dialysis initiated has increased in last 10 years at least 4 times. In 2011, the number of dialysis being done were 54,000, and in 2020 data shows that it is approximately 230,000 in 2020. So it has increased 4 times. But we should also remember that health is a state subject. The central government provides funding to the state. It is up to the state to see how best they can utilize the program with the given funding from the central government. The problem which it still remain unsolved is the manpower. We still have a large number of districts where the close supervision of nephrologists, whatever is planned 3 or 4 weeks, once in 3 or 4 weeks, is deficient, as well as the handling of the individual dialysis by the trained technical staff is also at the moment lacking. So these two things needs to improve for providing the better quality of dialysis. It is possible because cost has been decreased, and cost decrease is sustainable because the companies or the service provider are those people who have got manufacture of the machine and the consumable. And that is why with the government support of the local infrastructure and the inbuilt in-house manufacturing of the machine and consumable, the cost which is currently being accepted through the tender process is sustainable, and it is increasing every year. But again, the quality manpower of a nephrologist supervision and a trained manpower of providing individual dialysis still needs to improve on a wider scale. And the last thing which government is initiating is the peritoneal dialysis national program, which will contribute in addition to hemodialysis, and hopefully more number of the patient will be able to get the dialysis combining both modalities.
So we have Professor Vivekanand Jha here. He has raised the hands to make some comment. So please, sir, Dr. Jha. Unmute yourself, sir.
Yeah, thank you, Professor Prasad, for giving me the opportunity. So as we know that often whenever we start talking about kidney disease, it doesn't take too long before the conversation drifts towards dialysis, because obviously that is the most visible part of kidney disease treatment to the general public, and it is the cause of greatest amount of catastrophic healthcare expenditure. Now, it's great that multiple state governments and the union government is also taking initiatives, has already started initiatives to increase the access to dialysis, which is absolutely appropriate and important. But I think if we learn from other countries that have done this in the last 30, 40, 50 years, they have realized that just increasing access to dialysis is not sustainable, because the cost of dialysis is far, far out of proportion to the number of beneficiaries who will receive dialysis treatment. Of course, everyone who requires dialysis treatment should have access to dialysis in an equitable manner, absolutely. But I think the message of World Kidney Day is that kidney disease should be prevented to the extent possible. So that is a point I just wanted to bring the conversation back to it. so that we retain our focus on prevention, because ultimately prevention is what will lead to maximal health gains. We know that despite the fact that people can get dialysis, survival of patients on dialysis is much lower than survival of many types of even cancers. So our goal is to try and prevent people in early stages of kidney disease, or even those who have not developed kidney disease but are at risk, uh, so that they don't develop more advanced types of kidney disease and go on to require dialysis or develop other complications of kidney disease. So, and like I said before, now we know that there are many methods available that can allow us to prevent development of advanced kidney disease. What we need is greater engagement with our allies, our communities, for example, the patient community, the general community, of stakeholders, increase their awareness with help from other stakeholders, NGOs, press, etc. So I guess I would just want the conversation to be brought back to that.
Thank you. Thank you very much, sir. So just coming to that, the screening and preventable things. Dr. Arpita Rai, you have done a screening program in school children for kidney diseases about 8-10 years before. Do you suggest should it have opted across India? And what are the different challenges you faced if someone had sudden detection of some degree of the proteinuria or macroscopic hematuria on a screening?
What we did was a horizontal screening of detection abnormal urinary sediments. We always call that urine is the liquid kidney biopsy. So we thought, as many other countries, they have shown an excess of IgA nephropathy progressing to silent. Indian epidemiology of Indian IgA nephropathy is also like that, progressing silently to ESRD in early 2 decades, second and third decade. So somewhere in our mind, it was there that if we start screening from class 4th grade to 8 to 18 years children, we will find out many epidemiological risk factors as well as some urinary risk factors if they can be recommended for school health. Urine screening can be made a part of school health screening, as it happened in Malaysia, Japan, China, and has accounted for much decrease in the chronic kidney disease in next 20-30 years. So looking at that, we did a cross-sectional screening, which should be converted to a longitudinal screening by choice of some cohorts. And that longitudinal screening did show us that many children had both proteinuria and hematuria together, particularly in the age group of 12 to 18 years, which was quite in excess, and it should not be accepted smoothly. So to prove that these proteinuria and hematuria are significant, we need to screen them down the line twice or thrice before bringing them to the biopsy table and getting a true incidence of whether some subclinical glomerular diseases are responsible for early, almost Soros-CKD type of picture in the early adulthood. So that we couldn't replicate in a subsequent study, but what it also showed some evidence of childhood obesity. In the 8 to 12 years even, we accounted a lot of obesity, and the food habits also were not the ideal that should be there. So these are important epigenetic risk factors on top of the genetic ones that we share. So all these things, if we incorporate in our school health screening, it may result in long-term benefit. And what Sir was talking about, Professor Jha, by his insight that prevention is the 1 ounce of prevention may spend a lot of expenditure in future. We can replicate that thought and go in a tandem with that thought that this type of school screening, never in school screening, this urinary screening criteria is included. The obesity reporting is not included. two of which are coming up as important risk factors for long-term kidney disease. So this I want to voice through this forum, that we should give emphasis in this type of preventive studies starting from early childhood to address another cohort of CKDU where patient comes so late that we even cannot do biopsy, but to take them to dialysis.
Thank you, Dr. Arpita Rai, Chaudhary, for making this very, very important point that this should now be opted as we see the incidence of IgA nephropathy in our cohort. That is very frightening. Usually you see when the patients are coming already diffuse glomerulosclerosis, more than 50% of their glomerulus are already gone. So that is the, and in our scenario, we have seen more than 50% patients are coming with the DGS. So that is very alarming. Coming to Professor Ellen Almeida, sir. So really, you might have heard this about the chronic kidney disease, the situation in India, that it is being the leading cause of death in near future. So do you think, in your opinion, what are the actually real complications of the CKD if left untreated, undetected in early period, and the consequences which any people are going to face if they have not been intervened with the proper treatment?
Thank you, Narayan. Yes, we have heard of all the occurrence of chronic kidney disease and the burden it places on on the family as well as on the exchequer. Now, when you have a patient with chronic kidney disease, you need to suspect early, because if you have allowed the process or the progress of the chronic kidney disease, then you're going to land up with multi-organ damages. Even before you go on to the organ damages, you see a progression of the chronic kidney disease. In along with that, we could have cardiovascular diseases which abound in patients with chronic kidney disease, especially in the latest stages. The bones could be damaged, and that not only bones, even the musculoskeletal system would be the recipient of damaging effects of the renal failure. In addition, blood pressure too, either in its control or as a causation of the chronic kidney disease, would be enhanced. In addition, anemia, nutrition, and immune dysfunction would be something which would be a consequence of the failing kidney. Now, when you have a family or an individual who has a history of diabetes or hypertension, or there's a family history of kidney disease, or there is an existent congenital anomaly of the kidney and the urinary tract, you should be screening these patients for kidney disease. Because if you step in at the right time, you could at least delay, if not stop, the progression. The instance of all of us have experience of patients who have drug-related kidney disease, especially the analgesic abuse. And if you can get it early and stop this use, we can definitely stabilize the kidney function. So also with diabetes and hypertension. And as Vivek mentioned, there are now newer treatments which are beneficial in retarding the progression of the kidney disease so that we don't face an eventual cardiovascular disease and the other organ damages.
Sir, you have rightly pointed out that the chronic kidney disease is not only the simple disease limited to the kidney, but it involves rest of the organs of the body, like cardiovascular system, your CNS, uremic encephalopathy, if you are not taking CKD, MBD disorders, your bone becomes weak. You never feel well because of your anemia. So there are multiple problems that comes in, and so it is better to detect early and get it treated and retard the progression of the disease. And what are the consequences after that is that patient has to opt for the renal replacement therapy, and that becomes very challenging for them. So what do you think? What are the different challenges that anyone face in choosing this renal replacement therapy?
One of the first things which I find difficult at times, especially in the less informed patient, is when you try to tell him that, hey, your kidneys are not functioning well. He says, well, I'm passing urine. I don't have any swelling. I'm eating well. And this is what I had recently one patient who did just that. He had a creatinine in his 20s. And he says that I'm passing urine. I don't need dialysis. So this is the concept, the idea that my kidneys are failed. That's something which you really have to sell. And that comes from the lack of knowledge or awareness of kidney function and what does the kidney do in the body. We have been taught in school that the kidney is only an excretory organ, throwing out all the waste products. But it isn't just that. The kidney is also involved in the production of certain substances which keep us going, which preserves our bone, which ensures that we are not anemic, so et cetera, et cetera. I can go on in that fashion. But once you can get this idea across to the patient that, see, without doing dialysis or some form of renal replacement therapy, you would end up where you wouldn't want to be. Not only would it be a loss to you of your life, but even to the family of the possibly the only breadwinner. And whenever you tell a patient or the family that there is a need for dialysis, the idea which has to be conveyed to them, especially in chronic kidney disease, is that this is a long-term treatment, unless you have the possibility of a kidney transplant. And that is, in fact, a kidney transplant is the better form of renal replacement therapy. And that should be, the idea of a kidney transplant should be sold. The one question which they always turn around and ask you is it one kidney or two kidneys which have failed? So that is something which we have to say, that once your blood reports are abnormal, it means that both your kidneys have failed. You could have been born with one kidney and gone through life without knowing that you had only a single kidney, provided that kidney was functioning well. So the need is to continue treatment, be it dialysis. It's good that the government of India and state governments have provided such dialysis programs. I think Sanjay has rightly brought up the fact that to have the benefits of this program, you need to be well equipped, well staffed. There is governments are contributing money, contributing space, etc. But there are certain areas wherein the government gives money, and the money does not cover what we consider as ideal dialysis. Maybe they might just do two dialysis in a week, or they might just get one erythropoietin injection in the amount allocated for the. So then we have to find out what we have to expose them to. Sanjay again had mentioned about hemodialysis and peritoneal dialysis, and of course kidney transplant. So you need to educate them, tell them what you're getting into, because many people also may not be in a position to report for dialysis, hemodialysis. They have to travel long distances. Then peritoneal dialysis. But just the fact that you're staying too far away from the dialysis center does not mean that your choice should be peritoneal dialysis, because peritoneal dialysis has its own set of conditions which need to be satisfied. But after this is all said and done, the main thing is, if you are paying for your treatment, the cost factor is what will determine whether you can opt for it.
Thank you, sir. Thank you very much, sir. Thank you. So coming to Dr. Sanjeev Gulati, sir, you have worked in both public and private hospitals. You have witnessed several propaganda messages for curing CKD, making patients free from dialysis from all parts of India and the world. Do you see the effects of such message on the common public?
Wrong subject. This is, so you're saying like this, no? If you go,
there's a background voice. Yeah. So, Narayan, I think that's very interesting. And contrary to what may think, even in private sector hospitals where you manage relatively affluent class, people get misled by these messages. And the reason is very simple, because the treatment that we propose is cumbersome. You have a pill burden of say about 8 to 10 tablets. And we are very honest counseling them about dialysis and transplant. I mean, the video that you were referring to, the water bath video, interestingly, was forwarded to me by one of my patients who's an MBBS doctor, and he wanted to know that if it really works. So everyone wants to take an easier path. We live in our dreams. We think that, rather than spending a few thousands, if you can get cured by this simple treatment. And that's where the challenge lies, that we have to counter this. And as was earlier mentioned by my preceding speakers, by Justice Sachdeva, because that there is lack of any legislation. And Sunita Arons rightly said that, yes, we often tend to give one-sided view. So we have to counter this challenge. A lot of times our society we have spent hours, educating in CMEs and all. I think it's time that we spend at least some amount of time during the year in webinars like this, which you organize, interacting with the intelligentsia, with other Rotary clubs, and for the YouTube, I think since there is no legislation, you have to take them upfront on the YouTube. That's it. You add lime to remove lime. And I'll share with you some personal experience, during COVID time when we went into a lockdown. So I was just kind of browsing on the social media, and it was absolutely, amazing to see these videos who have few lakhs of followers. And on the social media, it is not the randomized control trials, not the almetrics of your publication that matters. People are misled by the number of followers. And anybody who's been on YouTube or social media, and you know that these followers can be purchased by boosting techniques. So I think it's time that the ISN makes a concerted effort. We have a YouTube channel of my own. I'll speak from my personal experience. So I launched my own YouTube channel since very few patients were there, and I have clocked already 1 lakh views on that. But by telling these people about simple information, what Sunita said, that we often talk in complex jargon. So you pick up common research which has come and tell them in very simple language that this is what this is. It's a randomized control trial. It is how do you license these drugs? Phase 1, phase 2, phase 3 trial. So I think it goes in sync with the theme of this year's World Kidney Day, that if we have to provide kidney health for all, we have to bridge this knowledge gap. And the menace of social media, whether you call it a menace, it's either boon or bane. We have to be a part of it, as well as the print media. We have to work together with them and spend substantial amount of time, rather than just doing CMEs with our, I'm not saying at all that they need not be done, but this is an equally important exercise. And I hope today's webinar is one of the steps in that direction which you have taken.
So thank you, Professor Gulati. Thank you very much. So I have kept waiting, Dr. Vasundhara Raghavan. Ma'am, now actually finally every brand goes to the patient, whether this is right or wrong. Any brand our patient is going to face. And you are in contact with these thousands of the patients across India, when many of followers are there in abroad also. So you are the founder member of the Kidney Warrior Foundation. So what the real need at ground level for these patients? What do you feel? What are the real need? Actually, how we should go to the patient?
Firstly, I will say that as soon as a patient is detected with the chronic kidney disease, there is a lot of confusion in the mind of the patient and the family. So we need a helpline. We need someone waiting just outside the nephrologist room to tell them, don't worry, there are treatments and you can live a long life. Can be 15 years, 20 years, not to worry, not to give up your schooling, not to give up your jobs. Because what they generally do is immediately the parents rally around the young people because today the youth are more likely to, more often getting the kidney disease, and many people are getting detected. So the parents keep telling them, don't worry, you can just relax, you take care of your health. They don't realize that they're encouraging them to take a very sad way out of the situation. They're not allowing them to face the disease. They're not allowing them the opportunity to finish the education, to earn, and to survive. Because the positivity of all these things are very have a great impact on the patient's life. So there has to be some sort of helpline. Kidney Warriors Foundation is always there. In case the doctors feel that they should be referred to us, we can always help them, stabilize them, refer them back to the doctor. Only that we will just make them part of a community where all the people are kidney patients and caregivers, and they feel more secure in the environment with which we are handling our patients. And yes, we don't allow them to discuss parallel alternate treatments. There's a big rule against so the admission itself is based on, we do not allow you to discuss the alternate therapies. So we are very clear on that. But it's very difficult to stop anything like this. The videos that came in had disturbed the patients a lot, and they wanted to try. They felt, okay, why are we stopping? Why are you stopping me? Why don't you talk to the doctors and let us see what it is? I said, I don't want to go backstream. I have to swim in the ahead. I can't go back and change everything. So you have to learn to manage your disease and take it. It's a frustration for people on dialysis. They just feel, let me get relieved, let me jump out of this, let me take the easy way out. So this is the issue that we faced. As far as the other issue is, the main issue is the finance. And Kidney Warriors Foundation is trying to look at a scheme, create its own insurance. But I think this is where all the stakeholders should join us. The government should try and help us to get a special insurance for kidney patients, which will be even covering the pre-existing, even if it means a little higher premium. And if it means that they'll not get 100%, but they will get about 60% relief or 40% relief, whatever it is. If something is better than nothing. Now they are paying about 3 lakhs to 7 lakhs, and income is about 5 lakhs. It's not worth it. These things don't work because the family cannot survive. They are a burden. The patient is a burden to the family, and he is suffering, he or she is not suffering only because of the disease. The feeling of being a burden is much higher, creating more depression for them. So we need to resolve the financial aspects, get an insurance scheme, which will give them little comfort. And we also need some subsidies for medicine, for protein supplements, which are highly priced. And yesterday I was in Vasai and I was seeing this patient from Nepal, and she was so weak and frail. And I had to say, yes, I can give you a protein supplement, but it can't be an ongoing project for Kidney Warriors Foundation. We have so many patients who need it. So there has to be an effort to bring the prices down. I don't know how it will be. Maybe the customs duties, the GST, anything can be worked out. But there has to be a recognition that patients are paying for their treatments, and they need to be feeling that they're part of a community that respects their payment, that respects and honors them for even being a warrior on a journey, which is very, very tough. It's not an easy thing. I can't even imagine doing dialysis one day. But people are doing for 20 years, 25 years, day in and day out, committed to their health. And the family is also taking it as a big commitment. And when the end of the patient's life comes to an end, the family will have seen that if they've lost a lot of wealth trying to support that one patient, and that person has not survived. So, it's a very sad situation. And this is something that we need to present to the government through the ISN, because I don't see any way Kidney Warriors Foundation can do this alone.
Yeah, I agree with you, ma'am. Really, your suggestion of the insurance, having this low budget medicines, low-cost medicines, and that are very great suggestions. And GST costing, and that should go low on at least dialysis-related equipments and dialysis.
Definitely. Even transplant patients are suffering. Because they don't
Transplant patients should have this.
Unfortunately, we think that after transplant, they are normal. And they also sit with the idea that we are normal and they're not jobless also. Not many of them have gone back to work. So situation is not very easy for us.
So coming back to Dr. Sanjay Agrawal, sir, sir, you were very close to most of your policymakers there in Delhi. So what do you think, how we can approach the policymakers to make it success? At least it should go to the government, and government should take care of this.
You see, my before answering to your question, what I understand, I just want to ask a question from Madam Raghavan. With your experience, Madam, why it is so that in Indian society, patient group are not strong? And I think that is a major lacunae if as a society or as a scientific body, if we go to government, somehow we are not listened by them as positively. My feeling is that a strong patient group, if approaches to the government, it will be little more easy that government is going to listen, and some action, whatever you suggested, those, I mean, there are many other actions also. Maybe some positive step. Otherwise, you see, there is a limitation of finances. Now, government has to see that in which group of diseases, how much finances is to be diverted. As such, we know that the government involve health, how much GDP portion government involves in the health. So truly speaking, if you see the, say, public health care system, I feel that health is not a priority for the government for covering whole of the population in the country, which may be physically not possible also considering the number of people, but still, public healthcare system, we know currently that 70% healthcare is provided by the private sector. And it's only 30%, and even 30% which is provided, it is both in terms of a quality as well as the quantity. Both are far less than what is required. So if balancing the funding of different, and then whichever group of diseases are more fascinating. I mean, people still, you ask somebody in a common society, everybody will tell they have listened heart attack or stroke or cancer. But if you ask chronic kidney disease, even a well-educated may not be even listen chronic kidney disease. So there are many things which needs to be improved before we will having some progress of significant nature in terms of the care of these patients.
So I think, sir, this should be the combined approach of the patient and the doctors, and then we should approach to the government that, and then I think they will listen. Sometimes, see, getting the opportunity, Pradhan Mantri National Dialysis Program has been launched. Once one of our ex-minister had suffered from this disease, and then he was influenced by some of the doctors, some of our colleagues, and then he has taken the action, and that came in reality. So that kind of the approach, I think we should make efforts, combined efforts from the patient point of view and from administrative point of view. And just coming out why it was that fascinating.
I will just give an example. Long back when the other immunosuppression was not being used and we were using steroid and azathioprine. And at that time, cost of azathioprine was significantly high. And some of the patient group from our hospital actually insisted and made a group and approach to minister and the government, and they could succeed in getting the cost of azathioprine decreased at that time. And same is true if you see Western, say, if you see UK, I mean, their patient group is so strong that they can insist that, say, initially YSET in a CAPD program was not being given in UK. But the patient group made a call and insisted that once it decreases the incidence of peritonitis, then why should we not be given YSETs?
Yes. So I agree with you. But when you look at this, is our responsibility being the nephrologist, that we should make aware the government and the public that chronic kidney disease is equally important. And now when you look at the data, cardiovascular disease has been decreased by 30% in the last 2 decades. Cancer by 15%, chronic lung disease by 41% during the same period, but our chronic kidney disease is going up. So we have to work all together to make the public aware that probably chronic disease is a more serious problem. You are going to see the more serious complications than other diseases. So that is our responsibility also. So Dr. Gulati, you have raised the hand. You have any comment?
So Narayan is just taking your thing forward, that I think from the ISN, we have to have a patient advocacy committee. I think we need to work closer, because on itself, there's no doubt that the Kidney Warrior Foundation is doing a yeoman's job. But I think if the ISN license with them together and then interacts with the government, it would probably make a bigger, the voice would be bigger. Ultimately, physicians sometimes are not heard or not taken seriously. But when a bigger community, acts together, so perhaps a licensing committee could be, formed where we could interact with the government. And I think Dr. Sanjay Agarwal would be the right person to comment on the feasibility of this. But some few of us
is a great suggestion.
should take a step forward, because as I said, we have to, if the second, I think we all agree that, that CKD is not being taken seriously. And I think in one of the very important takeaways from today's program has been what Sunita Aaron is not here, maybe, but she said that we have to highlight, patients of CKD are dying at the end, and what Dr. Vivekanand Jha is saying, that it's the third leading cause of death. So I think with the media together, there has to be a separate group of individuals who constantly gives these inputs onto the media, telling the public that, look, this is what is happening. The patient is dying of heart disease, but he had CKD. So death, I think we have to bring out more common, so that people, and the more important, the administrators take CKD seriously. That the biggest problem is right now, the administrators or the policy makers are not giving kidney disease its due. Yeah.
Vivek, you want to make any comment? You have raised your hands, Mr.
Yes, sir. I want to answer whether the Gujarat model of Gujarat dialysis program can be replicable in other states. We have already completed 15,40,000 dialysis sessions. And 2/3 of funding of Gujarat dialysis program is by central government, and 1/3 is by the state government. So I think the central government, it is by National Health Mission, NHM. So this model can be replicable in other states as well, but they have to demand to the NHM for this funding. That I want to clarify.
Thank you. This is a great suggestion.
I just want to add that this program of National Dialysis Program is actually out of through National Health Mission. So this is same program across the country. It is just question that some states are doing very good and some states are not doing as good.
Sir, for one dialysis, we are getting 1,650 rupees. Out of this 1,650 rupees, 1,100 is given by central government and 550 is given by state government. And we get additional 300 rupees travel allowance to the patient apart from this 1,650 rupees. So I think other states can do the same model.
Yeah, this is fine that some of the poor states cannot afford even 1/3 of their money for each and every patient below the poverty line. So it is possible that, but I think even Uttar Pradesh, lakhs of the patients are getting dialysis free of cost. So that
And
is what the
any
problem.
private hospital can also claim for this model, because we know that almost 3/4 of the health system is in the private sector. So if there is any private hospital in Gujarat, he can claim for this money under the National Health Mission.
Yeah, coming back to Dr. Almeida sir, you have raised your hands. You want to make some comment?
Yeah, basically, I think we're talking dialysis transplant. I draw back to what Vivek had mentioned. We should be thinking more of preventive. So, because whatever amount of finance that you have, whoever gives it, whether it be the central government or the state government, you're not going to have enough to run good dialysis centers and a good transplant program. So I think that's where the Indian Society of Nephrology should actually work towards having preventive programs and see that they work on the ground, not just in the conference rooms.
Thank you, sir. Thank you very much for your comments, sir. Vashundhara, Dr. Vashundhara, you want to
Yes.
yeah.
Yes, doctor. I just wanted to say that Kidney Warriors Foundation has recently started one initiative. We are Marian Manase. She's our brand development director. She's going around in schools to educate, to talk to the children about organ donation. And she's going to take a second round of school visits on salt. So how much salt should children be having? So some sort of a preventive program that we have started. I just thought I'll share it with you.
Yeah, this is great. Yeah, really, I have seen your some of the message that is really great. And that is the real things which is likely to prevent and reduce this burden. That is the real things. I think ultimately everyone will have to come back to the prevention, because the therapy is too costly for everyone. So coming back, Dr. Arpita, you have raised your hands. You want to make any comment? Yeah. Please.
Yeah, the same thing people were talking about, which is the improving kidney health literacy. It's not that kidney health literacy is not there among general people. It's missing in our colleagues, general physicians. It's missing in ourselves too. The way we are now proposing advocacy programs, that should include a broad base, and how ISN can translate it together with the stakeholders in each state from ISN by forming a general pattern of liaison with the policymakers, with the political people. The health literacy includes everything, because if health literacy improves, the admission rates go down, the overall scenario improves, and ultimately the cost burden goes down. That has to reach the policymakers, and in every field, that prevention of CKD, screening of the CKD, school children, or including the organ donation things in the school curriculum syllabus, and working on this lowering costs of dialysis and transplant. Everywhere we should be talking about it, and how these things may be implemented. That can be discussed in a broader level. I want to get inputs from seniors like Professor Agarwal, like Dr. Gulati, and like many other stakeholders who are there and senior to me and will help me working in this way with my state.
Thank you, Dr. Arpita. Dr. Vashundhara, probably Mariam is here, your brand ambassador.
Yes, she's here.
Does she want to make any comment? Mariam, you are here?
You're muted.
Yeah, unmute yourself and
Thank you, Dr. Prasad. So yes, the work that Dr. Arpita has already been doing is a new initiative from the Kidney Warrior Foundation, where we are reaching out to schools and colleges and starting to talk about preventive measures this year. But eventually, the next process to take this forward would be about going into scannings with schools and colleges and trying to create an awareness of early detection of CKD with schools and colleges. In addition, we're also talking about the hidden salt and sugar in packages food. And with Dr. Arun Gupta, I've been working with him. And with his help, we are able to create content that we're able to take it to schools and colleges to kind of create that awareness that this kind of food, the lifestyle changes should be started with the education system, curriculum, and the food that is available at schools. So this is somewhere we are started off, and I'd like to work with Dr. Aprita. Since Dr. Aprita has already done work on this sector, I would like to connect with her more and get her guidance to continue this work.
Thank you very much ma'am, for this great initiative, sir. So, Dr. A.K. Bhalla,
Yes. So,
so what
I
do you
think,
think, sir, from Indian Society of Nephrology,
yes,
we should do?
we have got very important inputs from all the panelists. Now, what society should do is, Indian Society of Nephrology, through its members, should conduct updates or make modules in association with Indian Medical Association as well as API, that is Association of Physicians of India. We have national branches, national as well as state branches. And to educate the physicians about kidney diseases, and main stress should be on screening and early detection of chronic kidney disease, especially in diabetes and hypertensive patients. And for that, already Indian Society of Nephrology has taken the initiative as a pan-India project with screening of CKD, especially in diabetic patients and hypertension patients. So that is one thing myself and Narayan want to share with you, is that already we have planned this activity. Secondly, we have to interact with policymakers and effective use of audiovisual media, print media, and involve ourselves with the patient. That is very important, that patient education, we have to concentrate on that by distribution of various pamphlets, by conducting workshops and small targeted meetings, closed group meetings. We are very grateful to our Prime Minister Modi ji for starting this Prime Minister National Dialysis Program and including PD also in 2019. And that is a step which Dr. Jha has already highlighted. That is not the answer actually. You are treating a very small population of dialysis patients, and our aim has to shift towards prevention. And we are only 2,000 nephrologists in the country, catering to such a vast country. So we have to involve the physicians and stress on preventive nephrology. That is the message actually, that we have to stress on preventive and nephrology and decrease the incidence and prevalence of end-stage renal disease patients requiring dialysis and kidney transplantation. As nephrologists, what minimum we can do is, we should screen all family members of diabetics, our patients, screen all family members of hypertensive patients who are coming to our OPD, screen all CKD patients, screen all dialysis patients, attendants of dialysis patients, attendants of transplant patients, and patients having family history of kidney disease. Make it a point that I'm sure we are missing. We are not screening all the family members of a patient who has got kidney disease. And last of all, which has already been highlighted, let's ask patients to make groups, dialysis patients, transplant patients, CKD non-dialysis patients, diabetic patients. That is already has been termed as patient advocacy. So these are the messages, I think, to conclude what we have gathered today after this 2-hour discussion. I am sure we are going to implement in true letter and spirit. Thank you.
Thank you very much, Dr. A.K. Bhalla sir, the President of Indian Society of Nephrology, for making this point and summarizing most of the things which have been discussed during the panel discussion. Just in the last round, I am coming to you all to have a final comments for the general public. What do you advocate for them? What is your point that should be taken from you, particularly the common people who is listening to you today? So coming one by one, Professor S.K. Agarwal sir.
Oh, I will say that no medicine on its own. If you are at a risk for developing chronic kidney disease, then annual checkup on a regular basis. And if you are on a medication for chronic kidney disease, then a regular compliance of medication and a regular testing. Don't depend on the symptom alone. Prevent chronic kidney disease by following healthy lifestyle.
Professor Gulati.
Yeah, I think highlight the 7 golden rules to prevent kidney disease, because prevention is the key. And along with that, emphasize in our communications with the public that to take, as you said at the beginning, scientifically validated treatments. I think that we should not name any treatment, but we request them that this is a serious disease and it needs serious thought and scientifically validated treatment.
Dr. Vivek, what point you want to make?
Yes, sir. I think during the COVID pandemic, we educated the mass population of India with the COVID cholera tune. So maybe government can use a cholera tune on various aspects of the healthcare, like prevention. So we can treat the mass population in a very cost-effective way. And prevention and early diagnosis, that should be the priority rather than treatment of end organ failure with the transplant. Thank you.
Thank you. Dr. Elmira, sir?
Yeah, basically, it was good to hear that the Indian Society of Nephrology is planning a preventive program or a screening program for diabetic hypertension. And also what Mariam said, and she's going to team up with Arpita and work on a group, a subset of patients, where preventive measures would definitely be of benefit. So what I would suggest is that we should identify certain areas, start small, don't try to do everything at the same time. And what you should do is select areas and get it working on the ground so that once it starts working, it won't stop. Then you can get into another program. And you need to take both the patient warriors, the kidney warriors group, plus there are a lot of NGOs who are working, but in isolation. If we could get all of them on board and have a joint program of the Indian Society of Nephrology with all these stakeholders, I'm sure that we will be successful.
Thank you very much, sir. Thank you very much for this excellent advice for our general public. Coming to Vasundhara Raghavan, ma'am, what message you want to give to the public today? Unmute yourself, ma'am. Unmute yourself.
The salt will be the focus for us, the limiting of salt and educating people on that.
Mariam, you want to make any comment? You have raised your hands, please.
Yeah. Yes, doctor. So while exactly what Dr. Allen and Dr. Sanjeev Gulati has mentioned, the 7 golden rules for prevention of kidney disease, while the ISN has these verticals ready, I think we as the Kidney Warrior Foundation will help in executing this as a ground level, because the Kidney Warrior Foundation is also a collaboration of other NGOs who are doing work on other sectors. So we can bring them together and be the linking factor between the doctors of ISN and the other NGOs. And like we start off small and from there, I think that would be a great initiative post this session to bring everything that we discuss to life. Thank you.
Thank you. Thank you, Mariam. Thank you. Dr. Arpita?
When I was in ASN, everything that has been told by my seniors to preventive medicine practice is absolutely severe. I am in the same line with them. So I'm not mentioning those. But when I was in ASN, I was seeing that how close ASN is to the policymaker group. I want to see my association, Indian Society of Nephrology, to be in that close association with government at state and central level for advocacy and policy making. The policy making has to be influenced by true ground researchers' opinion and the people working avidly in the clinical field. Thank you. Thank you for giving me the opportunity.
Thank you, ma'am. So, Dr. Balla, you want to make any final comment?
Yes, only thing I will write one line comment is that let's stress on preventive nephrology.
Thank you very much, sir. Thank you very much. Just I am summarizing what we have got from today's panel discussion for ourselves, for the society, and for the common people. The most important thing that Mr. Sachdeva, the justice, has advocated that any non-authenticated, non-validated treatment is punishable. So that we should understand, but someone will have to come forward for this. That is one important message should go around. Sunita Aron has advocated that the media plays great role, but the message which should go into the media, it should be very simple and understandable to the common people. Most of the times we write very much scientific language that is not understandable to the public. Dr. Vivekanand Jha has already pointed out it is a serious problem, common problem across the world, and preventive aspects is more important because the therapy later on, like the dialysis therapy, is costly, and even the developed countries are not able to afford free of cost. Professor Sanjay Agrawal sir has made very, very valid point. The chronic kidney disease is a very important problem across India, and he has also emphasized the making association, making collaborations with these NGOs and public and the doctors, the members of the society should approach in combinations to the government to enforce them to get subsidies on the medicines, to get off GST from the medicines, to make some of the drugs really affordable, and that can be made. And as he has pointed out, given the examples of some of the patients when they have approached to the government, really the azathioprine cost went down. So I think this would be the combined approach of the patient and the doctors and the society. So society should also come forward. Coming to Vivek Pute has made a very good examples of the Gujarat model that can be replicated, what he feels. And I also feel that being the similar model within the India, if the Gujarat can afford, any state can work, but we have to make our efforts to make it possible. Professor Sanjeev Gulati has already made a very, very valid points, and this today's panel discussion was his brain of child. He was thinking that this non-authenticated, non-proven medications is causing too much harm to the public, and that should not be adopted, at least by our innocent patient. Our innocent patients should be saved from this kind of the treatment. Otherwise, some of them are losing life. So that is very important point, sir. You have brought up the very right point. Arpita ma'am has already emphasized their experience with this screening in the school, and screening is the very important part in prevention of any onset of this chronic kidney disease. So that was her statement. Coming to Dr. Elmida sir. Dr. Elmida sir has already told prevention. And he has emphasized the complications of the chronic kidney disease, if not picked up in time, it is irreversible, progressive. Patients lands up with the end-stage renal disease, and ultimately dialysis and renal transplantation, a very costly therapy, not only for him, but for the country also. Coming to Vasundhara Raghavan ma'am, she is really today's very important message what she has given today. The patient's involvement and patient's advocacy is very, very important. And I think the way she is doing service for the society, particularly the patients suffering from the kidney ailments, is really recommendable. Thank you, Dr. Vasundhara Raghavan, for your all efforts. And really your suggestions and Professor Agrawal's suggestions that we can make efforts, go to the government. And we should have one advocacy within the Indian Society of Nephrology, so that that advocacy team will make some decision, make a draft, and we can put all together to the government. Your suggestion about the low cost insurance, low premium, at least even you are ready that some premium could be high, but the people should be ready to give that. Bring this treatment under the insurance cover, that could also be one of the medium for supporting the patients. So about making the patients, pupils, general public aware about the chronic kidney disease is the most important thing. The irreversible and progressive nature of this disease is very important thing, that everyone should take this message, particularly those who are listening today to us, and this would be on the YouTubes and everyone can listen this any point of the time. In the last, I will highlight those who are at the risk of chronic kidney disease, particularly our general public, elderly people who are above the 60 years, those who are diabetic, those who are hypertensive, those who are obese, those who have the family history of the chronic kidney disease, those who are chronic smoker, and people with the stone disease. They should screen themselves periodically for the involvement of the kidney by simple test, getting the routine examination urine, whether you have proteinuria, whether you have macroscopic hematuria, get your serum creatinine done. If it is elevated, you feel any signs and symptoms of the chronic kidney disease or any kidney disease, like the swelling on your body. If you have less appetite, your hemoglobin is unexplained and low. And if you are not feeling well, you are anemic. You have sometimes we have seen the patients, the bowing leg, the patients of the chronic kidney disease have bow legs, and they are coming to us in the advanced stage. Although this was the disease of the metabolic acidosis, renal tubular acidosis, that could have been prevented, that could have been treated. So all these things you should pick up. Whenever you have any signs and symptoms, any swelling, any hematuria, passing blood in the urine, passing protein in the urine, you have progeria, excess of the froth in the urine, बहुत ज़्यादा झाग निकल रहा हो, आप सोचो, you should get a screen yourself and consult your doctors. So thank you, ladies and gentlemen. Thank you for making and sparing your time for the today's panel discussion. And Indian Society of Nephrology would like to thank you again and again for your time and your suggestions and your efforts to making this program of the Indian Society of Nephrology very successful. Thank you, everyone.
Thank you, sir.
Thank you. Thank you.
Thank you, Narayan.
Bye bye. All the best.
Bye. Bye. See you all. Good
Thank you,
night.
Narayan. Very well done. Can we make a short summary of this, Narayan, and and send it to across to our media partners for
Yes, sure, sir.
Yeah, a lot of thinking has gone on, a lot of hard work has gone. Yeah.
Next time we can have patient advocacy group as a part of ISN.
I think so. I think that's it is time.
Yes. It was a suggestion of
Invite them to our
party, and we can have this advocacy.
annual meeting. At least one session we should have. Yeah.
You are online, by the way. Still live.
Yes.
Thank you,
Thank
doctor.
you.
Thank you, Dr. Narayan.
Good night.